Thanks, Chuck. Thank you very much.
You're good, buddy.
Chuck, thanks for that warm welcome. My wife would be proud. But here's what we're going to do today. So I am currently Chief of Staff in Philadephia. We have a fantastic hospital. And what I'm going to tell you is why I think we have become a referral center for kids with acute flaccid myelitis. Now, some of the points that Mark highlighted will be reiterated. As far as I'm concerned, repetition is good, and Janelle made some great comments. And I'm going to give you a little bit of history of how we got where we were in terms of nerve. So in our upper extremity practice, about 60% of our patients have nerve-related injuries, right? And that's where we've delved into acute flaccid myelitis. And we don't have the answers yet, like Mark highlighted, but we have some insight. So what is AFM? Let me just show you this. This is a kid from Paris, France, and this is Andreas. And if you look at Andreas, it's going to highlight his left upper extremity, which has lack of shoulder motion, lack of elbow motion, and pretty good hand function. Right? And if you look at him carefully, like Mark highlighted, his cranial nerves aren't all working. He's got this snarl on his left side that's actually adorable, but it's from a cranial nerve palsy, and he still has it today. And I'll show you what operation we did on Andreas and where he is currently now. In addition, Bryson, the one that Mark showed, we operated on last week from Pittsburgh, so there's a lot of kids that we've taken care of. But it is exactly like it says here. It is polio-like. The big thing for us, you know, we're orthopedic surgeons, so we try and make diagnosis pretty simple. So there's loss of motor, intact sensation, no spasticity. And the time course is distinctly different than kids with transverse myelitis. These kids get sick quickly and go down quickly, right? That's orthopedic speaking, orthopedics, right? So when they get sick and they go down, transverse myelitis is more prolonged and has sensory abnormalities and sometimes spasticity. So it's patchy motor loss. It often involves the cranial nerves. And the thing that's really been heartbreaking has been the diaphragm. So it involves a phrenic nerve and it involves a diaphragm, and then these kids can't breathe. And they don't end up on an iron lung anymore, but they end up on a ventilator. And I'm going to show you what that does to both their morbidity and their mortality. This is, again, I think I stole some of Mark's slides. Maybe I have some CDC in me. I can't give a talk without slides. But this is the confirmed cases in 2018, and we're now at the end of the outbreak in terms of surgical intervention, because we need to get to these kids by about 2 years after surgery, 2 years after the event. So we're getting toward the end. We're doing tons in the last couple months because they're coming from all over the place. And this is the reported cases that Mark also showed with this blip. Now, the one question I think is, why do kids come to us and how do they get to us? On the upper extremity team in our hospital, there's 2 surgeons, there's 8 occupational therapists, there's a bunch of nurses, and we have one person called the care coordinator, and her job is to facilitate getting kids from around the country to our shrine. That's what's happened, actually. Okay. And with social media, you know, these parents talk all the time, they want answers, and the kids are coming from all over the place to our institution. So what about our background? What made us ready to handle the AFM cases? I think it's because of our patient populations. We do care for a lot of kids with spinal cord injury. In the Shrine, like Chuck mentioned, there's 22 centers or 22 facilities. There's 3 that do spinal cord injury. There's us, Chicago, and Sacramento. So we have all that expertise from a therapy standpoint and from a surgical standpoint. We also take care of kids with transverse myelitis and brachioplex birth injuries when children are injured during the birthing process, and then traumatic brachioplex injury, they're riding their motorbike. And then we do a lot of peripheral nerve injuries. So we're really, really good at taking care of kids with nerve injuries. That's the bottom line. It's not just me, it's our nurses, it's our therapists, it's our care coordinators, it's everybody that's involved. We do a lot of established surgical techniques, like a nerve graft here, where a nerve is cut and then we graft the ends together. We do a lot of tendon transfers, which I'll talk a little bit about. But equally, we do what's called nerve transfers. Now, a nerve transfer means you take a piece of a working nerve and you put it into a non-working nerve. That's what you do, right? Now, you may say, how can you do that? God gave us redundancy in certain nerves. And you don't need the entire nerve. You can deal with a small part of it missing, because you don't need all those number of axons going to the muscle. These were the standard ones we use: the spinal accessory nerve, which moves your trapezius muscle, intercostal, which are the nerves between your ribs. You can take a piece of the ulnar nerve and a piece of the median nerve. You have to take it fairly high up into the armpit because that's where the redundancy is. As the nerve grows into the hand, you lose the redundancy. It's just the way we were made. Now what AFM has done, it's made us come up with all these new techniques and different techniques because it's different than spinal cord injury, which is usually injury across the spinal cord, and it's different than brachial plexus injury, which has common nerve root involvement. This is patchy, and I'll talk about that. Now nerve transfers are not new. What's interesting is they started in 1911, but then they fell out of favor. Nobody started reporting them until 1980s by Susan McKinnon, who's on the top, Jamie Bertellis, who's on the bottom of the left screen, and Christopher Oberlin, who's on the bottom. And if you look at what's happened, this is what Adolf described initially. These are the transfers we do today. It just got lost in the literature from 1911 to 1980. It's the weirdest thing, isn't it? It just never popularized. Now, look what's happened, though. This is articles that are published on nerve transfers. They've gone through the ceiling, right? And this isn't only because of AFM. This is because of brachial plexus injuries. This is because of people thinking out of the box and coming up with new nerve transfers. So it's really been fascinating. But again, the principle is to take a motor nerve and put it into a motor nerve to get motor function, like bending your elbow, or take a piece of a sensory nerve to put it into a sensory nerve to get sensation back. Now in AFM, they're all sensates, so you don't have to worry about sensibility. But at the same time, this is what we do with nerve transfers. In brachial plexus, it's pretty straightforward because there's a variety of different surgical options of nerves we can move, and I'm going to talk about them in a case example. So this will set the stage of what we can do and the results that we can get. So Andrew was a 14-year-old riding his ATV. He actually had a cervical spine fracture, but not a cervical spine injury. And he had a left brachial plexus injury. So if you see him on the picture, you can see his right arm and you see his left arm hanging by the side. This is just showing that he can't really move his shoulder at all. He can straighten his elbow. He can move his fingers and his wrist. And he can cross his fingers. Now all this is showing me is that there are nerves we can take a piece of. Right, the median nerve is the one that does the OK sign. The ulnar nerve is the one that crosses your fingers, and we can take a piece of them. We also looked at him carefully, and in essence, to make a long story short, he had pulled the C5 and C6 nerve roots from the cervical spine. That's called an avulsion. Currently, there are no surgical techniques to put them back in, so we had to think of something different, and that different would be a nerve transfer. So here's his x-ray, which shows the cervical spine fixed, and this is the example when they're avulsed from the spine. So what do? We think, right? And it's like everything else, right? If you think you're innovative, if you go back to 1911, you're probably not that innovative. But we try and think we're innovative. So we try and think of what we can do. And we came up with this surgical plan. So the spinal accessory nerve, like I said before, does the trapezius. You don't need your whole trapezius. The radial nerve has redundancy. We take a piece of the radial nerve to the axillary nerve, which moves the shoulder. Take a piece of the ulnar nerve to bend the elbow, and take a piece of the median nerve to further bend the elbow. All right? This is just a quick little example. This is not him. This is a baby. But it's just going to show you, wait, let me just move this. So this is a baby's arm on the inside, and that's a little bit of stimulation of the biceps, which isn't working well. That's a normal nerve. See that? That's the ulnar nerve. And what we're going to do is take a piece of that ulnar nerve and put it over to the biceps motor nerve, which isn't working. Right, so we're going to dissect the ulnar nerve into little fascicles, like you see here, and then we're going to take a piece of it that's motor and put it to the biceps. So that's one example of what we do and what we did. Right? Here he is 1 year later. Now, nerve regeneration is tricky. Nerve regeneration is 1 millimeter a day or 1 inch a month. That means after the operation, nobody's better. And you have to just stay the course and believe your nerve transfer or your nerve graft's going to work. So 1 year later, we're pretty happy with the elbow flexion, as you can see here, but we're not so happy with the shoulder motion. I'm going to apologize the way this works because the screen's not working, but that's his shoulder motion. Here he is 2 years later. Again, pretty good elbow motion, but still lacking shoulder. And then here he is at 3 years as an adult, because now he's got a beard. But you can see it's a pretty good result, right? So that's the foundation for nerve transfers. And that's the foundation of the operation that we do on most kids with AFM. That's a home run as far as I'm concerned. Now, since the animations aren't going to play, I just want to describe one more thing. What people don't realize is when you unfortunately sever your spinal cord, right, where you're severed, you knock out those anterior motor cells. So right there. And above, you're normal, right? But below, you're actually fine in terms of your motor nerves. They're just disconnected. They don't even know, right? They don't know that they're disconnected. That's why kids get spastic in their lower extremities. That's why we think there one day could be a cure for spinal cord injury. We just need to get rid of the bad part and attach the good part to the part that doesn't know it's disconnected. It's fascinating. And that's called an upper motor neuron. And I'm going to show you what we've been doing with this. So one of the problems in AFM is their diaphragm. One of the problems in spinal cord injury is their diaphragm. High-level tetraplegia, like Christopher Reeve's, average life expectancy is 10 years. How long did he live? 10 years, with all the care in the world. Because the pulmonary problems are just too far and too great. They get a mucus plug and they die, somebody's not watching, they die, and these kids die, and they die a lot. So what we've learned to do, if the injury is high, so C3, C4, C5, keep the diaphragm alive, right? 3, 4, 5, keep the diaphragm alive. But if they're even higher, it's disconnected, but it doesn't know it's disconnected. Does that make sense? Right? It doesn't know it's disconnected. So what we've been doing for these high-level spinal cord injury patients is we've been using a nerve stimulator or a nerve cuff, and we actually pace the diaphragm. So it goes to a pacemaker apparatus, it gets connected up, and then it beats, right, just like a pacemaker, and the diaphragm goes up and down, up and down, up and down. And you can do it on one side or you can do it on both sides if it's stimulatable. Right? Now, if it's below the level of injury, right, or it's in the zone of injury, so it's knocked out 3, 4, and 5, you can't stimulate it, right? But now we're sneaking below and taking a rib nerve called the intercostal, which is also not connected, but it doesn't know it's not connected because it's still going back and forth. And then what we're doing is we're transferring it to the phrenic nerve and pacing it. It's really fascinating. And we have done this in AFM to try and get these kids off the ventilator. This is how we used to do it. This is a big, ugly chest incision. This has a lot of morbidity. This is how we do it now, I think. Right? We do most of it thoracoscopically. We don't even open. Right? So we can harvest the intercostal nerve, we can harvest the phrenic nerve, and we can do all this via the scope. And our anesthesiologists are great. They drop one of the kids' lungs temporarily, and then they put it back up when we're done, right? And the big thing about this operation, that's the phrenic nerve there, is it is a game changer because then they're off of the ventilator, and then they don't die in 10 years, right? And then they can go to school. They're not stuck in an iron lung. They're out and about. It's really fascinating. Oh, let me just show. This is what it looks like when we're done. So this is a kid who has a stimulatable diaphragm now from that operation. So what you'll see is his diaphragm moving here. So the pacemaker is pacing his diaphragm and he's off the vent. Now it's not perfect. I mean, it's a big operation. One of the big problems, just like Chuck was saying, is the expense. Now, this is $50K, right? But the Shrine will do anything for children. Right? And so far, whatever we need, this is what we do. And we're actually getting insurance to pay for it because we tell them about the morbidity and mortality on being on a diaphragm. So in 2014, just like Mark said, along comes AFM. We recently had one of our fellows look up our AFM cases, and what we realized is that it probably saw us before we saw it. So we saw a lot of kids, not a lot, but a half dozen kids over the years that we said that they have a anterior horn cell disorder of unknown etiology. Sound familiar? So the anterior horn cell is the one in the gray matter. It's the one that's affected by polio, the one by AFM. And all these kids had intact sensibility or sensation. None of them had spasticity. We just didn't know what the hell to call it. I mean, that's the bottom line. And if you went back, it'd be interesting to see if they had this prodromal syndrome and if they had what led to AFM. But we clearly saw it before 2014. We're just not smart enough to pick it out. Now, most of them are shoulder and elbow weakness, which we'll talk about. The problem with the shoulder, there's no good tendon transfers. There are some good nerve transfers, and nerve transfers do better. But like I said before, in our practice, they can't be spastic, like a spinal cord injury patient, or transverse myelitis, and they have to have intact sensation. Now, this has been really challenging because, like we said before, the cranial nerves can be affected like you saw on Andreas. The spinal accessory nerve is often not working. Now, the spinal accessory nerve is a cranial nerve. Now, why a cranial nerve is not working isn't something we don't know. And the weirdest thing is we never see that in brachial plexus injuries because it's a cranial nerve. It's not from the brachial plexus. And in addition, the motor weakness is inconsistent. And Mark and I spoke a little bit about this at the break. So you can see, for example, an intact radial nerve, which extends your elbow, your wrist, and your fingers. And the wrist and hand is working fine, and the triceps isn't working. What the hell? Doesn't make any sense, right? Anatomically, it doesn't make any sense unless there's primary involvement of that muscle, right? That has led to damage to this, just those little teeny cells in the spine that control triceps. So now what we're doing is like we're taking pieces, literally pieces for nerve transfers of a nerve that's everything else is working except the triceps and transferring it to the triceps. So it's really been, for me, fascinating to take care of these kids. In addition, if their sensation is intact, the question is, does their muscle stay viable for a longer time? So if you cut your nerve, right, and your muscle is at the end of the nerve, so it comes from the spinal cord through the nerve to the muscle. What happens is the muscle initially is going, what's going on? And then over time, the muscle's like screaming, help me, and that's where you get EMG findings. And then over time, it dies. It truly dies. So a normal muscle is nice, pink, red, and juicy, looks like a fillet. A dead muscle without nerve looks like chicken. It's pale, it doesn't stim, and that's what happens. In normal nerve injuries, that happens between 18 and 24 months. That's what happens. That's why we need to see these kids early, right? So one plea to the community is to get these kids to us early. And what's happened with this social media is we're getting the kids early, which is good. Although now we're seeing late kids late, because if you think about it, 2018, you know, they're a year and a half out, and we're really pushing the window because we got to get the nerves back together because they only grow 1 millimeter a day or 1 inch a month. So again, this is a diagram that's not going to work because the screen's not working. Like someone asked Mark, it has clearly been reported elsewhere. This is a series from Taiwan that had 17 cases related to 71 and not 68. And now what we did recently, which just got accepted to Annals of Neurology last week, so I'm going to share you our limited experience. So we've seen about 60 kids, and we've done upper extremity operations on over 30 of the kids, right? And that's what we've looked at. And it's interesting because we think we need to get our data out, not just to publish, because all that does is add to those 84 pages that Chuck was talking about. But so when people see these kids, there's some preliminary early data, they can make decisions. You know, there is a little bit of a schism in kids who take care of AFM. We think they need to be addressed in a timely fashion. There are a bunch of people who think we should watch and wait because they're going to get better over time. That has not been our experience. Clearly, there are some kids that get better, but after a while, you know, you gotta poop or get off the pot, right? You gotta make a decision about whether you're going to intervene and change what we call the natural history, right? And some of these kids are profoundly affected. So we looked at our data so far. They had to have AFM, they had to have nerve treatment. If we exclude them, if they weren't followed long enough, and they had other procedures, and we looked at what's called AMS scores by our occupational therapist, which is this test, which is a really good way to assess motion in children. So we use this in our brachial plexus patient. You know, one thing that we really want to have after this relative spike is data. Data to make educated decisions, right? And a lot of the old polio data, for whatever reason, is not very good. Sure, they get better, but we want to know how better they actually get, right? So we record this with our therapists who are depicted here, and they look at all this data and they get it over and over again. And if I'm doing an AFM case or a brachial plexus case at 7:30 in the morning, they come in at 6:30 to get the data right before. I don't want to hear, oh, I got it a month ago. I don't really care about a month ago. What I care about is right before I intervene, because that's the data that counts. So here's just an example, a smattering. A lot of different nerve transfers were performed. And again, ones that we've never done just based upon available donors. So this is just a long laundry list of the available donors. We had 30 patients we looked at. We only had 11 patients with adequate follow-up. Like Mark said, the average age of onset was 3. It is clearly a male disease for whatever reason. In our patients, 64% had upper and lower. The rest had just uppers, and 9% or 10% had facial nerve palsy. And these are the nerve transfers. We did about 35 nerve transfers on these children. Again, a long laundry list of what we're trying to reanimate, but if you look at it carefully, it's mainly the shoulder and elbow, right, that we can do. And the kids that are profoundly affected, you know, where they're just paralyzed and they're on a ventilator, there is not a lot we can do, right? And it is a tragedy for that family. And one day this kid is fine, and the next day he's not fine, and it's heart-wrenching for these families, right? And they come to the hospital together, they bond together. It's probably something that we offer to them that we could never offer, because nobody wants to be different. Right? Nobody wants to be different. And the one thing that's great about our practice, whether it's this diagnosis or arthrogryposis, they're all there together, and now they're not different anymore, which is fascinating. It's a huge thing in the Shrine. If you look at our results, so what you want to look at is really the green ones, or the green in the whatever color that is. But it looks like the nerve itself did make a difference as long as we chose a good nerve. But I'm going to show you something else. This is probably the best thing. It's a heat map looking at prior to surgery. Now don't get confused, there's 11 children. They're just numbered as we collected them. So even though it says 15, that's only 11. Because if you look, there's no 8, there's no 10. But that's our 11 kids. And what you want to look at is anything that's gone from like a red to a green. This is an orthopedic's dream, right? We don't like real complicated things. We want to know if it's red and it goes green, that's a good day, right? If it's red and stays red, that's not a good day, right? But this is what we've shown on our patients at follow-up. And if you look at it, right, if you just take one quick look, and I won't bore you with the details, if you look at elbow flexion on the left compared to the right, elbow extension on the left compared to the right, we're really good at it. Right. Now, I don't think we're any better than any other surgeon. I think there's something else going on. And if you look at shoulder abduction is lifting your arm up, and shoulder exrotation is catching a ball, we're not so good at it. There's something funny about the shoulder in kids with AFM. Now, the shoulder, no doubt, is complicated. You know, it has a rotator cuff, and it has a deltoid, which have to work in concert. Like a pianist and a cello player, they have to work together. The elbow, honestly, is a dumb joint. If you think about it. What does it do? It goes whomp, it bends, and it whomp, and it straightens, right? So some of it is a dumb joint versus a complicated joint. Because we've seen the same thing in our brachial plexus population. We're much better at restoring elbow flexion, almost 90% of the time in plexus kids. Shoulder, a little bit hit or miss. Here's an example. So let me show you. This is Scarlett. Right, so this is her pre-op examination, right? She's a kid from Boston. So she has good elbow extension, right? So that's important. She can't bend her arm. You'll see this. She just can't bend. That's her trying to bend her arm. You have to be careful because kids will cheat. You can't let them throw it up, right? They'll do anything. And this is her shoulder, which has nothing, nada. So she has no rotator cuff. That I'm looking at her trapezius strength, which is okay. And she has no shoulder. That's it. Right? And she was a year when she came to see us. So here's what we did. So we did a nerve transfer for the shoulder, a nerve transfer for the other shoulder, so one to the cuff, one to the deltoid, and one to bend her elbow. That's all you need. And here she is at a year follow-up. Wow. Yeah, it's remarkable, right? Right? Not perfect, but clearly the most beautiful child I could find. Right? But again, if you look at it critically, right? The elbow is absolutely fantastic, right? And the shoulder is good. It's not a home run, it's probably a triple, right? But when you have, there's a famous hand saying, if you have nothing, a little's a lot. And their family's ecstatic with her outcome today. And she's still going to get better. She's only a year follow-up. Here's another example, so I don't want to play this yet. So this is a 2-year-old who had, the nerve transfers are listed on the left, but let me just break it down. He had nerve transfers for shoulder range of motion and nerve transfers for elbow flexion. He is our best shoulder result to date. He did not have a spinal accessory nerve, so we actually took nerves from his ribs and put them up to his rotator cuff. something we've never done before, this group of, or this cohort of patients, a new transfer of. Well, we may be doing it more because you're going to see this. We may be doing it a lot more. Watch this. That's amazing. Yeah. Right, so that's his shoulder. And that's, I think, because of this new transfer, right? And you'll see him, he's cheating a little bit as he leans away, but there's his elbow flexion. Sometimes I think they just want to run out of the room, actually. Right. But it's good, because our office hours look like a playground. There's no white coats or ties. It's totally fine. But that's what we can do when it works, right? This is a great slide. I may not be able to get this to work, but the dad, because this is the kid from Paris, right? So the dad put this slide together, and because he sends it to us for follow-up. And what you can see, I'm going to see if this is going to work. It works when you use, it's not going to work. It works when you do the whole slide presentation. But this is where he started. He's much younger here too. That's his right side, but he has nothing, right? And then here he is 3 months. You're not going to expect anything. It's too early. You're not going to see something before about 6 months. You're still not seeing much. Now 9 months after surgery, you're starting to see something. And then here he is. This video was just sent to me at a year. I mean, just literally sent to me, right? Yeah, so he's getting it. He really is. So I think what happens in patients with AFM, if they have persistent motor deficits that haven't changed after 6 to 9 months, and they're seeing us, and we can find a donor, we're going in. Now, do we know? We don't know. But the greatest thing about following these kids with that active movement scale is you know they haven't changed. So if we get the patients early, start measuring them, and they haven't changed over 4 or 5 months, they're not going to change. Unfortunately, there's not going to miracle is going to happen. It's hard for us when we see these kids like right now. We're seeing them for the first time. We haven't seen them 6 months ago or a year ago, and now we're trying to make a surgical decision. We're much better at the elbow than shoulder, although you saw some good shoulder results. So we want to see these kids early, and we think that we can push the envelope. So even patients that are after a year from their AFM, we're operating on. Bryson's over just about a year. What we've done in the country, which is interesting, so Amy Moore is the pretty woman in the middle. She's good friends with us. She has tackled the legs, right? So we decided collectively that somebody needs to tackle their legs, see if they can get these kids to walk. So the bad ones, right? We don't do it. We send them all to her, right? And she sends most, she's a little stingy sometimes, but she sends most of her arms to us as long as they can travel, right? So, and this is a guy named Matt on the West Coast who's doing arms. But Amy's doing the legs primarily because they're transfers we've never, ever done before. And sometimes you have to go in the pelvis, you have to find these nerves. I don't even know where they are anymore. So it's just crazy. But so it's interesting. And collectively, I think we're trying to make a difference in these patients. They all talk to each other, so they all know us and they all know where to go. It becomes a sticky wicket. You know, when healthcare gets involved and insurance gets involved, you know, we're at a total benefit at the Shrine, like Chuck said. We don't care. I mean, we really don't care. If we can get the kids there, we're going to take care of the kids, and there's no bill necessary. So we're trying our best. And I need to end this in just a couple more slides. I think you have to celebrate the small victories. This is Andres. So his dad sent me this picture recently, right, the last one. And my partner's Dr. Z, and I replied, I didn't know he danced like Dr. Z. Thank you very much.